Thank you. All right. Now we're going to talk about new treatments. I want to emphasize that this is a new age of targeted treatments for neurodevelopmental disorders. And this came about, of course, because the development of animal models with known mutations allows people to look at the neurobiological pathways that are dysregulated and then to try treatments in the animal models first, and then the treatments can be tried in individuals with the disorder. I, of course, will be talking about Fragile X and all of these interventions here. But for many other disorders, there are new treatments, even Down syndrome, where you think that, gosh, nothing could reverse having an extra chromosome 21. But actually, we know in Down syndrome that there's way too much GABA inhibition in the brain, which is just the opposite of Fragile X. There's actually downregulation of GABA inhibition that causes all that impulsive behavior that Chris Oliver talked to you about. But in Down syndrome, there's way too much GABA inhibition, and so a GABA-A alpha-5 inverse agonist, which is a fancy name for an antagonist, is being utilized now in clinical trials, and the preliminary studies have shown that there is some beneficial cognitive outcome with using this medication in Down syndrome. In Rett syndrome, the IGF-1 or insulin growth factor 1 analog is being used. For those of you who see Prader-Willi syndrome, know that growth hormone has been very helpful. But in tuberous sclerosis, some mTOR inhibitors are being used. Minocycline, I'll talk a little bit about that in Fragile X syndrome, and the Angelman syndrome people started using minocycline first in the Angelman syndrome mouse model. Ed Weber and now is doing clinical trials in Angelman syndrome with minocycline. And there are other medications that may be helpful. Topotekins. I actually edited a book just recently that I gave to the resource center here at Frambu about new targeted treatments for neurodevelopmental disorders, with a chapter on several different neurodevelopmental disorders. And actually, many of the problems that we see in Fragile X also occur in autism. There's downregulation of the GABA or the inhibitory system and upregulation of the glutamate or stimulatory system. Common problems in mTOR, microRNA dysregulation that Gri talked about with premutation also can occur, different molecular cause of the microRNA dysregulation in autism. There are also mitochondrial abnormalities that occur in almost all of the neurodevelopmental disorders. Oxidative stress, we'll talk a little bit about the use of antioxidants. And then many neurodevelopmental disorders are quite vulnerable to environmental toxicity, as we'll talk a little bit more in my final lecture. And then, of course, other commonalities include the FMRP deficits that we talked about in the last lecture. So the Fragile X protein, you have to think of it as a mother protein because it is a controller of translation for hundreds of different messages into their respective proteins. It not only transports the messenger RNAs to the synapse, but it controls the translation of hundreds of messages, particularly messages that are important for synaptic plasticity. By that, I mean how the synapse changes with environmental stimulation. So FMRP is a major controller protein thought to control at least 50% of the genes important for synaptic plasticity. So the absence of the Fragile X protein, because it usually suppresses translation, then there is an increased production of a lot of different proteins. Probably about 20% more proteins occur in the hippocampus and other parts of the brain of individuals with Fragile X syndrome. Maybe that's part of the reason why they have a bigger brain. There's a lot of protein production going on. One of the elevated proteins is MMP9, or matrix metalloproteinase 9, which is also a very important protein. When it's too high, it interferes with the development of the synapses. And that's thought to be maybe another cause for why the synapses are weak. Bringing down the MMP9 levels to normal is thought to be a very important part of treatment. So there's upregulation of what we call the metabotropic glutamate receptor 5 pathways. And these are pathways that lead to what we call long-term depression, not psychiatric depression, but synaptic depression, that is weakening of synaptic connections. Downregulation of the GABA system, dysregulation of dopamine, enhanced amyloid precursor protein production, increased oxidative stress, and damage to neurons. And as we mentioned before, enhanced release of neurotransmitters presynaptically so that the synapse is kind of flooded with neurotransmitters. So this is the mGlu-R5 pathway, and this leads to long-term depression or weakening of synaptic connections. And when this pathway is stimulated, it produces proteins that pull in this AMPA receptor. FMRP puts the brakes on the mGlu-R5 pathway, but when FMRP is not there, there is enhanced protein production, enhanced internalization of the AMPA receptors. So when these receptors gets pulled in, the synapse gets weaker and weaker, and that's thought to be the reason why there's intellectual deficiency in Fragile X syndrome. This is called the mGlu-R5 theory of Fragile X. And when this came out in 2004, people thought, well, gee, we're just going to use mGlu-R5 antagonists and we'll cure Fragile X. And indeed, when they used that in the mouse model of Fragile X, it did rescue all of the problems associated with the Fragile X mouse. And the mouse was smarter, less hyperactive, anxiety was better, all kinds of things changed, synaptic structure changed too, to be much stronger. And so now we know it's easy to cure the Fragile X mouse. It's a little bit harder to cure Fragile X syndrome. These are the mGlu-R5 antagonists that have been tried. So they're downregulating this pathway, which links to the mTOR pathway, which is upregulated actually in tuberous sclerosis. Lovastatin is another medication that tends to lower this part of the pathway. We call this the MEK-ERK side of the pathway. There's other treatments that we're going to talk about. Arbaclofen stimulates the GABA-B pathway. Minocycline lowers MMP9. There's also medications. Ganaxolone is one, and allopregnanolone is another. And acamprosate is actually a medication that's used for alcoholism, where when you take acamprosate and you're alcoholic and you drink alcohol, you start vomiting and get very sick. So it's a treatment for alcohol abuse. And acamprosate is being studied now in Fragile X syndrome, and there's a limited amount of data that shows that it can be helpful for some aspects of Fragile X syndrome. So we'll talk about all of these, and I apologize for getting so molecular with you, but sometimes it's important to think about the molecular underpinnings that you can reverse with some of these targeted treatments. So this is the Phenobom study, and we're cheering. I think this is one of the happiest days of my career because we took this Phenobom, an mGlu-R5 antagonist produced by Neuropharm, And we gave it to actually 6 different patients with Fragile X at our site and 6 patients at Liz Berry-Kravis's site in Chicago. And we saw amazingly great effects. These are adults with Fragile X syndrome. Here's one of our patients, and I remember this day very well because he came in very anxious, impulsive, inattentive, and sat down. We gave him a Phenibom orally, and within about a half an hour, he was a completely different person. He was less anxious. He started verbalizing a lot more. He did a continuous performance task, which he completely aced. He got everything perfect. We also had what we call a pre-pulse inhibition task, where there's a deficit in Fragile X, and it improved on this medication. And he even asked one of the nurses that had set up an IV during this trial out on a date. And this is a shy guy who, doesn't do these things. And so we thought, oh, my God, we're curing Fragile X syndrome. And the mother's very happy here. And this was an amazing day. The problem is that Neuropharm had a long-acting fluoxetine preparation that they were studying in autism. And it wasn't efficacious in autism. So the company went bankrupt. And so when it went bankrupt, Phenibom was no longer available. So Phenibom kind of got lost in the dust, but there were other mGlu-R5 antagonists that we've studied, and I'll show you the results of those in a moment. But this was a pretty positive day. However, Novartis and Roche had 2 different mGlu-R5 antagonists that we tried in controlled trials, and neither of these trials were efficacious. We actually did see some patients that did have improvements, but the majority did not. And in the outcome measures that they utilized, which were mainly behavioral outcome measures like the aberrant behavior checklist, they did not see improvements. We and other sites did not see improvements. However, the Novartis and the Roche studies did not address learning and cognition. These were basically behavioral measures that they utilized. They didn't have any learning paradigms. We had a few patients that learned how to read on the longitudinal follow-up study. And some individuals really made some amazing gains in reading and different kinds of work gains, but it wasn't captured on the outcome measures. The problem is the studies have to be designed in certain ways, and our FDA or Federal Drug Administration needs a single outcome measure, and if you don't show efficacy on that, it's not a positive study. And so both Novartis and Roche stepped out of the Fragile X field. However, these were adolescent and adult studies, and the Novartis people, we are actually very interested in looking at the Novartis medication. It's called AFQ-056 in individuals between the ages of 3 and 6, because in the preliminary studies we saw several patients that were not verbal that just started verbalizing very well on AFQ-056. So we think that maybe younger children will show a much more positive effect. And language learning is actually a cognitive task, not a behavioral task. And so I think that this may be beneficial. So the Novartis people will give us the drug if NIH approves the study. It's going to take place at multiple sites through a mechanism called NeuroNext. And so we hope we get funded by NIH. We shall see. The next one I want to talk about is our baclofen, which is the right isomer of baclofen. It's a GABA B agonist. It works presynaptically. As you can see here, it actually lowers the amount of glutamate coming out here at the synapse, and that decreases the stimulation to these mGlu-R5 receptors, and so that lowers the excess protein production that's present in Fragile X syndrome. Here is the structure. It's thought to be far more potent than regular baclofen. We did an initial study that we published in 2012 where we saw, as you can see here, the light blue is our baclofen and the dark blue is placebo. And even though the overall responders was not statistically significantly different, those that had autism or those that had low sociability scales on the aberrant behavior checklist actually had a significantly positive response. Like this little boy with Fragile X syndrome and autism who doesn't want to get into the hot tub here, although I don't think I'd get in there either. This initial positive study led to 2 phase 3 trials. That means a broader trial taking place at multiple centers. And this was in both adolescents and in children. Children 5 to 11 and also 12 to 21 in autism spectrum disorders. The problem, again, was that in the autism spectrum disorders, it did not show efficacy. And here you can see the autism results. There was no significant benefit in the autism study of individuals 5 to 21. And so the problem is that companies can go bankrupt when they don't show benefit in autism. And of course, the problem with autism is that it's very heterogeneous. So you are probably mixing apples and oranges and lemons together, and they're not doing any stratification in the phenotype of autism. And so the company went bankrupt, and now Autism Speaks controls our baclofen. It was sold to Autism Speaks. And the Autism Speaks people say that they will fund autism studies, but not Fragile X studies. So when the data was done on the adult baclofen studies here and on the pediatric baclofen studies here was finally analyzed, and it hasn't been published yet. What was found is that the adults didn't show efficacy on the outcome measures, but the pediatric group did show it on the aberrant behavior checklist. Irritability was improved on our baclofen. The parent stress index was improved. The main outcome measure, which was the social avoidance scale on the aberrant behavior checklist, was close to significance, but no cigar. So the company went bankrupt, actually, before this data was analyzed, which is too bad. But there was some ability or some benefit, if you will, shown in our baclofen, and it clearly needs further testing in individuals with Fragile X. The problem is for most clinical trials, you get a third that do very well, and the other 2/3 that may or may not have a positive response. And it could average out to showing no overall benefit, whereas a subgroup, if it was characterized well with some biomarkers, may be able to demonstrate efficacy. So I had another patient that was on the baclofen study, and several individuals who did well, we kept them on for 2 years. And this boy, who started out with an IQ in the mid-60s, actually learned how to read during those 2 years on the baclofen study, and he read the Harry Potter books and several other series of books, the Hardy Boy series, which is very popular in our country. And when we enrolled him in another trial a few years later, the metadoxidine trial that I'll tell you about in a moment, his IQ had jumped to 86. So I think that there is some benefit from long-term treatment, particularly if it's combined with intensive educational interventions, and we'll talk about that towards the end. So I want to address this enhanced protein production. Lithium, which has been helpful in an open label study in Fragile X, lowering this GSK3 beta excessive protein production can be helpful in Fragile X. Minocycline is what we were very interested in because it's an antibiotic that is freely prescribable, and it's known to lower MMP9, which is way too high in Fragile X syndrome. Now, minocycline does have a history in that it was extremely helpful for the mouse model of Fragile X, basically rescuing behavior deficits and cognition in the Fragile X mouse. We published a survey several years ago looking at minocycline after the mouse studies came out. Everybody wanted to be put on minocycline. And we did show that about 70% had a positive response, particularly in language with limited side effects. A trial, an open label trial was done up in Canada. And there was also a trial in autism, a very small trial that's been done in autism, but significant efficacy was not shown. Now, minocycline can cause some graying of the teeth, as you see here, and sometimes it can be darkening of the nails or sometimes even darkening of the skin or the gums. And those are the main side effects. In rare cases, it can cause a severe headache, or increased intracranial pressure, or pseudotumor cerebri. So if individuals get a severe headache, they need to be taken off. And in very rare cases, it can cause a rash or a lupus-like syndrome. And usually the anti-nuclear antibody increases when those side effects are developing. So we check an ANA about every 6 months in individuals that are on minocycline. Now, minocycline is a drug that has a lot of different effects. It has anti-inflammatory effects. It has anti-apoptotic effects. That means it can prevent neuronal cell death. It definitely lowers MMP9, which strengthens the synapse. But it also has antioxidant effects, and we do know that there's a lot of oxidative stress in individuals with Fragile X syndrome. The other important thing that minocycline can do is it can stall translation. So FMRP, you remember, inhibits translation, and so the minocycline effect of stalling translation can kind of mimic some of the effects that occur similar to what FMRP does if it was in place. And so this stalling of translation may be very helpful for downregulating more than one protein, more than just MMP9. So we did a controlled trial that was a crossover trial. So they were on each arm for 3 months. So if they were on the placebo arm first, then they went to minocycline and vice versa, with outcome measures at these 3 time points in the beginning and in between and at the end. And we were using doses of 25 to 100 milligrams related to age and weight, and we did from 3.5 to through age 16. We actually saw several individuals that responded fairly well. The blue is minocycline, the red is placebo, and as you can see, there were some placebo effects also, because over a 3 and 6 month period for the total study, there's a lot of development that occurs during this time for this age group also, but there seemed to be a better effect with minocycline compared to placebo that in an intent to treat analysis, it was statistically significant, but the effect was not strong, but was significant. And again, it's sometimes hard to show an effect in everybody. Usually you get a subgroup that has a great response. This is an older guy with Fragile X who was too old for our study. He's in his late 20s, early 30s, and he's one of the most severely affected with Fragile X that I've seen. He actually is severely autistic and nonverbal, refuses to wear clothes, and likes to sit just in this area in his room at home. and play with his toys here. He's pretty aggressive. He wouldn't tolerate clothes, and he wouldn't go outside, and they couldn't bring him into clinic. And I've tried him on just about every medication known to man, including benzos and atypical antipsychotics, and just a variety of meds that have worked with patients with Fragile X syndrome. But nothing really has worked well. So I said to the dad, I said, well, let's just put him on minocycline. He's too old for the study, but let's just see if it does anything. And actually, after 2 years on minocycline, he was able to tolerate getting dressed, and he's almost dressed here. I don't think he's reading National Geographic, but at least he's looking at the pictures. It's better than playing with these balls. He's drinking from a cup. He's able to verbalize more. His aggression, his dad said, is gone, and he is supposed to come to clinic, but he hasn't done it yet. So we shall see, because we'd like to add some newer medications to this. But he's certainly much improved, and Dad is very thankful for minocycline effects. So I think that it sometimes can work in adults, and I've had other adults that have done well. We've looked at a biomarker. Remember, I talked about these habituation deficits in Fragile X, and we have been able to show with event-related potentials, actually, that habituation improves to repetitive clicks on minocycline versus placebos. So a subgroup, we were able to do event-related potentials, and we saw improvement in the habituation by ERP studies. You have to be able to put an electrode cap on the head and do some event-related potentials, but there are some ERP biomarkers that did improve, and the habituation is a very core problem in Fragile X. We are actually used a biomarker, MMP9, and in general, we've shown that MMP9 is elevated in Fragile X, and we can watch it come down during the come down during the minocycline phase and then go up again during the placebo phase. And so we'd like to get funding to be able to correlate outcome with the level of MMP9 elevation and how it responds to minocycline, but we haven't been able to obtain that funding yet. So I'm going to jump to another treatment, and that is sertraline. And sertraline is a selective serotonin reuptake inhibitor. So it allows more sertraline to stay in the synapse. And this is a medication that we use all the time in individuals with Fragile X to treat anxiety. And the serotonin system is basically a system that's very important in the limbic areas of the brain, but also occurs frontally and throughout the cortex. And there's some old data from Diana Chugani looking at PET scanning in individuals with autism, and these are not Fragile X individuals, but showing that young children with autism, particularly those under 5, have lowered levels of serotonin, and this is in the frontal area of the brain. I think that the use of SSRIs in autism went down dramatically a few years back when Brian King and others showed that individuals with autism did not demonstrate efficacy overall as a group when treated with citalopram. But if you look carefully at that paper, I think they had only one patient who was 5, and the rest were, I think, 6 to 17. So these were older kids that did the King study. We were very interested in treating younger children. Also, after this paper came out in 2013, showing that syndromic and non-syndromic forms of ASD have reduced tryptophan. And these were metabolomic studies on lymphoblastoid cell lines of a variety of different subtypes of autism, and showing that the enzymes leading from tryptophan to serotonin. All of these enzymes in blue here are all dramatically downregulated. This maybe is one of the mechanisms why there's low serotonin levels early on in individuals with autism. Now, I started using sertraline in young kids with Fragile X mainly because of anxiety. And anxiety has been correlated with autism. The more severe the anxiety, the more severe the autism in a couple of studies. Now, SSRIs also stimulate neurogenesis in the mouse and in humans. And SSRIs stimulate BDNF, which is brain-derived neurotrophic factor, which in the mouse model for Fragile X is known to rescue basically most of the features of Fragile X syndrome in the knockout mouse model. And sertraline has a calming effect to the anxiety. And what I noticed when I started using clinically is that kids seemed less anxious and talking more. And I thought, well, maybe they're just talking more because they're less anxious. But maybe there could conceivably be a direct effect of sertraline on language. And then I was finding that a lot of families were telling me that, gosh, attention was better too. And in further reading, sertraline is the only SSRI that stimulates dopamine in the striatum and in the nucleus accumbens. So it may be improving attention too. After we were seeing some positive effects, I had one of my students, Ian Wernarni, take a look at a retrospective study of young children between 12 and 50 months of age with Fragile X who were either treated with sertraline or were not treated with sertraline, and look at the language trajectory. And here's what she found. Basically, expressive language trajectory, this is on sertraline, and this is no sertraline treatment. It was better in those on sertraline. At least it was steeper. The language was getting better faster. And the same with receptive language. This is on sertraline, and this is with no sertraline. So we published this, and this data was enough to get us funding for a controlled trial of sertraline, a blinded controlled trial randomized to either sertraline or placebo. We are actually just finishing this study, but we did an analysis of the first 30 patients. We tried to get close to 60 patients. The last patient to be on this study will have the data taken in July, and we were able to get 54 in this study. But the first 30 that were analyzed showed that those on sertraline, this is on a global impression scale or CGI, the sertraline is in red. There were many more that were very much improved or much improved compared to placebo. There were other benefits too, also in attention and in socialization. We're looking forward to analyzing the full study to see if we can show a definite effect. And so we're talking about low dose sertraline. Basically, the doses are at 2.5 to just 5 milligrams. So it's very low level. If kids get hyper-aroused on 5 milligrams, then they get dropped down to just 2.5 milligrams. And usually we do not see a hyper-arousal. You basically want to stimulate language, but not stimulate hyperactivity. So I just want to show you how it's working out clinically, because we are treating more patients clinically. And so this is a little girl that at 18 months, she had an unfavorable activation ratio. That means the percentage of her X chromosomes where the normal X is active was in 24%. So her prediction for having significant developmental problems were high. In general, about a third of girls with the full mutation are intellectually impaired. About a third have an IQ in the borderline range, and about a third can have an IQ in the normal range. But even those with an IQ in the normal range can have significant attentional problems or language difficulties. So at 18 months, her receptive and expressive language on the Mullen was at the first percentile. She was started on sertraline then at just 2.5 milligrams. Later, she was increased to 5 milligrams, and both doses showed an improvement in language. Mom is a special ed teacher, so she did a lot of work with her at home. She used a variety of learning tools, including an iPad. Minocycline was started when she was 2, first at 25 milligrams, and later that was boosted to 50 milligrams, and mother again saw an improvement in her language development. Now at age 4, on the Stanford-Binet, her full-scale IQ is 100. She is on the hyperactive side, but she is an early reader, and right now she's in kindergarten and doing very well in regular school. So GABA. The GABA system is downregulated. This is the inhibitory system. And again, there's many disorders. I think most of the disorders that Chris was talking about, where there's significant impulsivity and executive function deficits, I think their inhibitory problems are related to GABA downregulation. So people are very interested, both in the autism field and in the Fragile X field and for many other disorders, getting a good GABA agonist. So ganaxolone is one that was produced by Marinus, and we were funded by the Department of Defense to study ganaxolone in individuals 6 to 18 years of age in a controlled double-blind crossover trial. And Frank Cooey in Belgium is actually doing it in Antwerp, also following our same protocol. And so they are on 6 weeks of ganaxolone, tapered down and crossed over to placebo, and it's a double-blind crossover. So we hope to finish this trial this year. I think Frank Coy will finish this year also, and so we'll analyze our data together. I want to say that you can upregulate GABA by doing yoga and mindfulness meditation. And this is a high-functioning Fragile X guy who tells me that he does yoga every day, and it helps him remarkably. He's high enough functioning that he was able to do the classes, and his IQ is in the borderline range, so he's able to work and to live independently from his family right now. And he uses this. It helps with mood stabilization. So metadoxine is a new drug. How am I doing for time? Okay. Okay, so let me just get through a couple and then we'll finish. So metadoxine was developed by an Israeli company called Alcobra. This is a medication. It's different than a stimulant. It has pyridoxine B6 combined with a pyridolone ring, or PCA ring. It's short-acting. It was approved in Israel and several other countries for alcohol intoxication, and that's where the name Alcobra comes from, and it actually enhanced cognition in chronic alcoholics. It has also shown efficacy for individuals with ADHD, so working via a GABA mechanism to stimulate GABAergic inhibitory transmission via presynaptic mechanism. And now it is being tried in Fragile X, and I have to say it's a blinded controlled trial, but I can tell who's on it and who isn't. I think it actually works pretty well. This is a multi-center study, and so we should, for individuals between the ages of 15 and 55. So it's happening at all these centers and also in Israel. So we should have data on that before too long, and I think that this will probably be approved by our FDA. I also want to mention that IGF-1, the insulin growth factor, analog has been very helpful for repetitive behavior in individuals with autism that have a SHANK3 mutation or Phelan-McDermid syndrome. It's also been helpful in Rett syndrome, and we are currently looking at it in Fragile X syndrome. It was developed by Neurin, a drug company that started in, it's been bought by an Australian company, but it started in New Zealand. But this downregulates that ERK signaling pathway, and in the mouse model, of course, it's easy to cure the mouse, and even the testicular size improves in the mouse model, and ERK and AKT biomarkers go down with treatment, and dendritic spines improve dramatically. So I have high hopes that this IGF-1 analog will be great. So this is very similar, when you give a person growth hormone, IGF-1 is produced by the liver. So it may have some very positive effects, just like growth hormone has been helpful in Prader-Willi syndrome. I just want you to know that FMRP controls all. It also controls the endocannabinoid system. And so many families are very interested in marijuana. The problem is that one study shows that use of marijuana can be helpful in Fragile X. This study shows that using a CB1R blockade, rimonabant, is better in Fragile X syndrome. But I think that some of the CBD analogs will be helpful. Not the THC psychotropic aspect of marijuana, but the CBD stimulators. There's probably hundreds of natural cannabinoids. So studies will be taking place with that. I also want to point out that even antioxidants like vitamin E, which is alpha tocopherol, and N-acetylcysteine has major effects in the animal model, the mouse model of Fragile X, and a clinical trial is going on by Yolanda de Diego in individuals with Fragile X between 6 and 18 in Spain, and she and I are talking about maybe trying antioxidants in very young kids with Fragile X. And for those of you who are our omega-3 buffs, in the knockout mouse, omega-3s increase BDNF, or brain-derived neurotrophic factor, in the hippocampus in the knockout mouse. I recommend antioxidants, omega-3s, green tea, blueberries, etc., in individuals with Fragile X, and the omega-3s can help with a lot of different phenotypes in the mouse model. 2 new treatments for autism and Fragile X. One is bumetanide. It's being tried now in autism by the people in France. And there's one case study about it being helpful in Fragile X syndrome, and a group trial in autism already published. And Suriname, Naveau et al. Recently published a paper about Suriname, which is a tryptophan antibiotic. It's a purogenic antagonist that's been used to treat some tropical diseases, including sleeping sickness or trypanosomiasis. And it has many effects, including lowering that PI3 kinase, ERK, and AKT pathways, and they found it very helpful in the Fragile X knockout mouse. So there's a variety of new medications coming up. But I want to end by saying, if you're going to use a medication to improve synaptic connections, you definitely have to use the educational and behavioral interventions to teach them something to really enhance these synaptic connections now that they can improve. And we published a study with CogMed. It's a computer attention training for individuals with ADHD, and it did work with the majority of Fragile X. HeadSprout, another digital reading program for those with dyslexia. It actually has been helpful in Fragile X. A variety of AT devices and even iPad apps can be helpful. So there's a variety of new teaching techniques, but you have to have these people in a learning environment, I think, to improve. It would be nice to have a spray FMRP, and my husband's lab is working on small molecules to upregulate FMRP levels, particularly if people are producing a significant amount of message. So sorry for going over, but that's just an overview on some of the new targeted treatments that are available. Thanks.